Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and today we're talking with board-certified rheumatologist Dr. Robert Goodman of the Arthritis and Rheumatology Clinic right here in Shreveport. Thanks for joining us, Dr. Goodman.
Glad to be here.
Yes, so today we're talking about lupus, which is something that you've seen for most of your career, and maybe a reason why you got started in rheumatology. Tell me a little bit about it.
That's right, Courtney. When I was a young medical student here at LSU Shreveport, one of my first patients that I was assigned, when we rotate through as a medical student, you rotate on medicine, pediatrics, surgery, and when I was rotating through my medicine rotation, internal medicine rotation, I was assigned a patient, a young lady who was about my age, and she was being affected by lupus. It was affecting her kidneys, and it was affecting the way her blood clotted, and it was causing catastrophic problems for her. She was in her mid-20s, and she was facing being on dialysis. We had very few tools to treat her at that time, but my heart just went out to her, partly because she was about our age. Most of our patients, you know, when you're in your 20s and a medical student, most of them are decades older, but it was just such a striking disease, and it led to my heart going out to these patients. And so I'm sort of circling back today as I'm approaching the end of my career to bring attention to this disease. We've made a lot of progress. There's a lot of hope out there if you suffer from lupus, but and we can talk about that in the body of this webcast.
Absolutely. Yeah, so approaching the end of your career, so at the end of this year, right?
That's right. So I'll be retiring as of December 31st, and so this is my second to the last appearance on Channel 3, or as I mentioned to Nate, my penultimate appearance. And for you kids out there, you might want to know that term because it'll be on your ACT and your SAT vocabulary. And it's bittersweet. I've enjoyed working with you and Nate and Brian and all the folks here at Channel 3.
We always say that you're a wealth of knowledge, and so I know that it's beneficial not only to us, you know, here in the studio, but other people that are listening. So we just appreciate, you know, just the value that you bring. So
thank you.
Yes, so it's really, like you said, a cool full circle moment that you've had, you know, seeing one of your first patients in medical school with lupus, and now being able to talk about this disease. So tell us, you know, what is lupus and how does it affect an individual?
Well, lupus is a very interesting story. It's a very interesting disease. In the 12th century, a monk who was writing in Latin saw that some people, and he was in Eastern Europe, in what would be modern day Romania, maybe modern day Yugoslavia, saw patients that would get a rash on their face when they were out in the sunlight. And this rash reminded this monk of a wolf that they have in Europe that has kind of a buff-colored or red snout. And so he described that, and of course, monks in the Middle Ages were very judgmental, unfortunately, and they thought that these people who got this disease were somehow at fault, which was a very common problem in the Middle Ages, and even today, that we tend to blame the person with the disease, which we shouldn't. But he thought that they were worshiping a wolf, and the Latin term for wolf is lupus. So that was described in the medical literature as a skin rash that reminded somebody in the Middle Ages of the snout of a European red wolf. Those people would get rashes that would be worse when they were out in the sun, and so they might go and harvest their crops and if they're in the northern hemisphere, if they don't harvest enough crops, they'll starve to death through the winter. They would be harvesting their crops in the full moon of October and November because they don't have a John Deere tractor with lights on it and they realize my rash gets worse when I'm out in the sun. The other villagers, the other people in my community point at me that priest or monk is being very judgmental, so they would harvest their crops at night. Now they call them lunatics or loony. And so then the lupus story takes us to 1895. Dr. William Osler was now the head of internal medicine at Johns Hopkins Medical School. And Dr. William Osler found that some of these people that got the skin rash of lupus that had been described 700 or 800 years before might also get problems with their kidneys. They might also get problems with their joints. They might also get problems with inflammation around the lining of their lungs or their heart. They might also get problems with blood clots or inflammation of the arteries. So they were getting a myriad of problems, not just the skin, or not just the cutaneous lupus, which would be skin lupus, but throughout the multitude of systems in their body. And he coined the term systemic lupus erythematosus, bringing it to, hey, this person having kidney problems, this person's having problems with inflammation in their joints, inflammation around their heart, the lining of their heart, and maybe they're having problems with blood clots. And he put together this whole packet and called it systemic lupus erythematosus.
Gotcha.
William Osler went on to have just an astounding career, and he's considered the father of internal medicine. He was at internal medicine at Johns Hopkins, and then just before World War I at Oxford in London, England.
Very cool. Yeah, and when you talk about rheumatology, you're an expert in this, and you kind of talk about it as like a syndrome, a running together of symptoms. So
Well,
is that kind of what
exactly
that is?
it, and that's exactly it. So that a monk in the Middle Ages described this lupus skin rash, and he used, and so all of medical writing, or in the Middle Ages, the official language, the official written language was Latin, and so he wrote in Latin that he thought that they were related to the wolf, and the Latin term for wolf being lupus caused that to stick, and that's why we still have this disease. He could have used a modern term and said it's a butterfly rash, but you know, priests and monks can be kind of judgy, and they called it lupus rash.
Okay.
And that brings us up to the 20th century.
Wow, yeah, thanks for that very brief history lesson. I love it. So with the rash, since we're kind of on that topic, is that always the case? Does every person that has lupus also have a rash? Or?
Well, in lupus, you quickly learn that you can't say always or
okay.
never. And so many studies will look at 100 patients with lupus and find that 80 or 85 out of 100 will at some point in their medical history have a rash that is worse when they're out in sunlight. The other chronic rash that's common is psoriasis. And psoriasis gets better when you're in the sun, and a lupus rash gets worse when you're in the sun. Then they might also have painful and swollen joints that looks a lot like rheumatoid arthritis. They might also get kidney damage. They might get their kidneys spilling protein, or their kidneys putting out blood, and it might remind the doctor initially, does this person have a urinary tract infection? Does this person have some other reason to have kidney failure? But it's the immune system that is damaging the skin and cause these terrible skin rashes is also damaging the kidneys. And the kidneys then become less efficient in filtering our blood, and they become less efficient in holding the proteins into our body, and so a person spills proteins into their urine, and that could cause them to have kidney failure and to end up being on dialysis. Selena Gomez, the pop star, apparently had significant lupus kidney disease and had to get a kidney transplant years ago.
Yes, I remember that. And so, you know, since those symptoms do kind of vary from person to person, as you mentioned, can't really say always or never. So how do you know what to look for when you're diagnosing this disease?
So over the years, there's a checklist of ways in which the immune system could misbehave and be part of lupus, and these are called diagnostic criteria. And so they have a list of, if this lab test is a certain way, and if this person's swollen joints are this way, and if they have the skin rash, and if they have kidney problems, and you put together, and the committees of doctors will meet in maybe 1988 and create the diagnostic criteria for lupus, and then they will revise them in 1994. And then a committee of doctors in Europe will have an updated criteria for in 2006 or 2018. And what they're doing is trying to use what statisticians would say is multivariate analysis, which they're looking at these 10 or 15 or 20 different pieces of data and saying, when can we all be assured at a maybe not 100% certainty, maybe not at a 99% certainty, but maybe at a 95% certainty that if a doctor in Sydney, Australia, or a doctor in Singapore, or a doctor in Seattle in the Great Northwest, or a doctor in Shreveport, Louisiana, is seeing these 6 things on this list of 18 things, that they would conclude that that's probably lupus. And that's a running together, a syndromos running together of a bunch of symptoms, and it's a classic way in which many diseases are diagnosed. Cancer, on the other hand, it's usually diagnosed based on a biopsy, but lupus, you're putting together this diagnostic puzzle. It's very much like a medical detective trying to solve a whodunit.
Okay. Well, we have our first caller, Dr.
Okay.
Goodman. Tracy, thanks for joining in. What is your question?
Hello, Tracy.
Hello. My question is, I was diagnosed with tamoxifen-induced lupus.
Okay.
I don't take the tamoxifen anymore, but I still have flare, and I wonder, will I always? Is that something that will go away, or am I always going to have that?
Well, thank you, Tracy, for that. When Dr. William Osler was describing lupus, he was describing idiopathic lupus, and meaning we don't know what triggers it. But Tracy has tamoxifen-induced lupus. In the 1960s and 1970s, it was starting to be noticed that some people would have an allergic reaction to certain medicines. And back in the 1970s and 80s, some of those medicines were medicines for hypertension, medicines for seizure disorders, medicines for cardiac arrhythmias, and even a medicine for tuberculosis. And they could fool the immune system into causing what would be called drug-induced lupus. So those 4 medicines were listed on medicines that could cause drug-induced lupus. Since then, Tracy, tamoxifen and 20 or 30 other medicines have been added to that drug-induced lupus category. The thinking on most of the time when you take away that stimulus for drug-induced lupus, most of the time the flares will get further and further apart, and then they might go away altogether. Many times your doctor or rheumatologist will see a lab test called an antihistone antibody that will be positive, and it's in the myriad of lab tests that they would do, and if it's positive, they'll say it's probably your tamoxifen, and usually, not 100% of the time, because we've already said it's never always or never with lupus, but most of the time, the incidences of drug-induced lupus will get further and further apart as time goes by. In the meantime, many times doctors might use the medicine hydroxychloroquine, which is a classic medicine for idiopathic lupus as well as for drug-induced lupus, and then they would use steroid medicines. And hopefully the need for steroids will just be very infrequent and become less and less frequent as you go forward in time. I have had some patients, not many, but a few, that continue to have lupus even after what I thought was drug-induced lupus, and it lasts, for years. But a big percentage, maybe 85% of the time, it should become less and less frequent as you're away from your tamoxifen. I hope that's helpful, Tracy.
Yes, thank you so much.
You're welcome.
Yes, thanks Tracy for your question. And if you're just joining us, you can talk to Dr. Goodman at 318-219-4569. We're talking about lupus, and if you had a specific question for him, give us a call. And so lupus is something that you'd say is pretty common.
Well, it's not as common as rheumatoid arthritis or psoriatic arthritis, but lupus occurs in about 1 person in 18 or 1900. It is more common in women. Women get lupus 8 times more common than us guys, and it's more common in African American and Hispanic women. And I also have some patients that are in our viewing area in southeast Oklahoma, in McCurtain County, that are Choctaw Indians. And so Native American Indians do tend to get lupus, as well as a cousin of lupus and rheumatoid arthritis called Sjogren's syndrome as well. So it tends to be occurred women, African American, Hispanic, as well as Native American.
And would you say that contributes to risk factors, like those things, and anything else?
That's right. And the other risk factor is genetics. If you have a family member that has lupus, your chance of getting it is about 1 in 5.
Gotcha. Well, it's important to know, maybe talk to family members if you have that. And would you suggest be on the lookout for those symptoms, or it doesn't mean that you're going to get it just because you have genetics, but just kind of be on the lookout.
It doesn't mean you're going to get it, but some of the things that a person could have, if they have a sibling with lupus, or if they have a family member with lupus, a couple of the things, many of the patients with lupus, it'll get worse when they're out in the sun. So if you and I get a sunburn, if I get a sunburn, my skin cells will then turn over, and my immune system will look at these skin cells that are being recycled. These skin cells, when I get, will have more turnover if I get a sunburn than in general. And when these skin cells go through this recycling process, it is called apoptosis. So when I get a sunburn and my immune system is looking at my skin cells going through this process called apoptosis, that says, oh, that's Robert's skin cells. Don't worry about him. He's just a knucklehead. He should have worn sunscreen. But if somebody is prone to get lupus, they might get, their immune system might say, hey, wait a minute, this stage of breakdown of these cells looks suspicious, and they attack that. Their immune system attacks those cells and causes the skin rash that occurs just after they've been out in the sun. So avoiding the sunlight, wearing sunscreen, wearing an SPF 50 makeup is important. Having your vitamin D in a good normal range, in the middle of the normal range, and I know Courtney is a dietitian, and she knows the importance of vitamin D. Many of the research centers, including Johns Hopkins, that is now 130 years after William Osler was there, are leaders in studying lupus, and they would say, have your vitamin D in the middle of the normal range. The normal range is between 30 and 100 international units, so push it up to 40 or 50 and 100. So sunscreen, vitamin D. And thirdly, a low inflammatory diet can be very helpful for lupus, and you can go on the websites to check out those low inflammatory diets.
Absolutely, yes, great advice, I love it. So, we talked a little bit about how lupus is treated. You've said hydroxychloroquine is one of those. What else would you say people should consider? And when, if someone knows that maybe they've been diagnosed with lupus, or maybe they think they have it, when should they see a doctor?
Well, they probably should see a doctor if they have some symptoms that are skin rashes or swollen joints or fatigue, and it's been lasting longer than a few weeks, and especially if the skin rashes are causing scarring, then they need to see their primary care doctor. Depending if it's predominantly a dermatologic issue, they may end up in a dermatologist's office. If it's predominantly a kidney or a renal issue, they may go from the dermatologist, from their primary care doctor to a nephrologist. Sometimes they might end up being with a rheumatologist as well. And so a lot of times it's a team of doctors that are trying to get to the bottom of it. But if they're having symptoms, if they tend to get symptoms that are persisting for a few weeks or a month, talk to your primary care doctor about it. Lupus is going to be way down the list because it's most likely going to be something else. But as those something else's are ruled out or felt to be not a viable diagnosis, And if more and more features of misbehavior of the white blood cells start to develop at week 2 and week 4 and week 6 of your disease process, then that's when lupus might become a more viable diagnosis as more and more and more pieces of this diagnostic puzzle point towards lupus.
Okay, yes. And with the treatment options, once they come to see you, then you have that opportunity to have that individualized treatment approach.
Absolutely. We still have to rely on steroids. If a person is very sick and they're in threats of their kidneys are getting worse and worse and worse by the day, and they're in a hospital, a lot of times we still have to use steroid medicines. That's a medicine that can change the course of the disease in a matter of hours. So 12 or 18 hours, you can start turning the corner with steroids. And that might be intravenous steroids if somebody's really acutely sick with lupus in a hospital. Outside of that setting, many times they would be getting your vitamin D in a good normal range, making sure the diagnosis is viable or correct with lupus, and probably considering hydroxychloroquine. They may use steroids just briefly for those flares of lupus. If hydroxychloroquine does not work, in the latter part of the 20th century, we would use medicines that we lupus doctors borrowed from our kidney transplant colleagues. Some of those medicines were a medicine that was called Celsep or myclophenolmoflutil, and another medicine called Imuran or azathioprine. And that was about all that we had. And sometimes we would borrow medicines from our cancer chemotherapy colleagues, and a doctor would be treating a cancer of the immune system like leukemia or lymphoma, and we would reluctantly borrow medicines like Cytoxan in the 1990s even through 2005 or 2010. But finally, in 2010 and 2018 and in 2021, some new approaches that are more targeted towards where we think the immunologic problem is, so that we aren't causing as many side effects with the steroids. Hydroxychloroquine still remains a key central part of it, having your vitamin D in a good normal range, using sunscreen, but then the doctors have another set of tools that they can open this new set of tools in our lupus toolbox to really get people to a lot better state of health with a lot fewer steroids.
Yeah, and that's important, especially because steroids can increase your blood sugar levels as well. And
absolutely,
they
do havoc on our blood sugar. They do havoc on our cholesterol. They cause us to have, and because they're carpet bombing the immune system, they render a person more likely to have opportunistic infections with steroids, and the list just goes on. And so where steroids were sort of a mainstay, we want to get away from them. We want to use them just very wisely, but in a very short period of time.
Yeah.
And then we have these more targeted approaches. One of those is called Benlysta. Benlysta blocks the B lymphocytes that are being stimulated. So Benlysta is a B lymphocyte stimulator blocker. There's another medicine called Safnola and Lupkynis, but I think we have a caller on the phone.
We sure do. George, thanks for joining us, and what's your question?
Yeah, I have a question. I've been to you several times, and I hate to see you go.
Well, thanks, George. That's very nice of you to say.
And this is getting off subject just a little bit, but you're going to be gone, so I wanted to ask you. I've had pain in the right hip for a while, and they think it's probably bursitis. Can they usually differentiate between bursitis and arthritis on the X-ray, or how's that go?
Thanks for that call, George. There are several ways to differentiate. If a person, and if the doctor examines you and has you lay on an exam table, and if they can twist your leg, if they can have your leg go out and in and flex and extend your leg, and that reproduces the pain, then that's probably true arthritis in the hip joint. If you have pain where the doctor points in what we would call in football, a hip pointer, which is approximately right here, the camera may not see it, that would be possibly bursitis. So bursitis on physical exam will produce tenderness in the patient when you palpate that hip pointer, which is called the greater trochanter. There's a bursa there, and that is the common bursa that is seen with hip pain. But if the pain is reproduced when the doctor internally and externally rotates their hip, the patient's hip, then that's probably arthritis. It is true that the most common type of arthritis, known as osteoarthritis, will show up on plain x-rays. And that's really the most common type of arthritis, and that is usually, it's helped by medicines. We rheumatologists have some medicines to help the pain of osteoarthritis, but we don't really have that home run hit with OA yet. And a lot of times you're ending up, if it is almost bone-on-bone osteoarthritis, they may need a total hip replacement. On the other hand, if it's bursitis, it might respond to some medications. It might respond to a shot of cortisone in the bursa that can be done in a doctor's office. Usually it doesn't have to have x-ray guidance to put a shot of cortisone in a bursa. Physical therapy is often used. And then there are a variety of medicines. Many of them are generic, and many of them cost under $4 that can help. So physical therapy, medications, and shots of cortisone can help bursitis. They can also be good for osteoarthritis, but if osteoarthritis is the dominant thing and it's end-stage osteoarthritis, you may end up being in an orthopedic surgeon's office to get a hip replacement.
If you have one of the arthritises in the hip, is it more likely to be rheumatoid or regular arthritis, or
it's
can
probably,
it be any of them?
Because osteoarthritis, George, happens to about half of us as we get over 50. It's the most common type of arthritis. But you can get, rheumatoid arthritis can cause arthritis in the hip as well. But rheumatoid arthritis usually also is causing arthritis in the small joints of the hands. The disease lupus can cause hip pain as well. Sometimes it's due to the classic inflammation of lupus in the joints, but they would be having other things. They would be having the skin rashes, they might be having the kidney problems and other things with lupus. And occasionally, unfortunately, as Courtney has already pointed out, not only can the steroids cause problems with cholesterol and things, the steroids can cause a special type of hip pain that is called avascular necrosis of the hip. That means poor circulation to the hip. And that's a similar problem to what happened to Bo Jackson that ended his career as a running back in football. So there's a variety of things that can cause hip pain. Osteoarthritis is one, and it's probably the most common. Bursitis is a close second, but you need to see your primary care doctor. I will be still seeing patients until the end of December, so George, if you want to come in and let me take a look at it, I'll be glad to confirm which one it might be. But thanks for the call.
Yeah, thanks, George. We've got just about 90 seconds left. So, I don't know if you could maybe mention what a lupus flare is in 30 seconds.
Well, a lupus flare might be a person having very bad skin rashes, very bad swollen joints and tender joints. They might have a flare of more kidney failure or more problems with whatever is causing the main symptom of lupus.
Okay, so it's like you already have lupus, but it's just kind of inflamed.
The symptoms that you're having are a lot worse, and the inflammation is just a lot worse.
Yeah.
Need steroids and then get on a chronic treatment that is some of these other medications to keep the number of flares further and further apart so that you have fewer and fewer of them, and hopefully you can almost get lupus in near remission. We never use the term remission, but sometimes with these medicines like hydroxychloroquine, a medicine Benlysta and Safnola and lupkynis, our young rheumatologists. There's a lot of nice female rheumatologists now taking my place in Shreveport-Bossier, and they can get you to a good place.
All right. Well, Dr. Goodman, we have one more Healthline coming up next month, and you're still going to be around, but
Okay.
but not maybe in that continuing basis. You're accepting patients for consulting until
Just
December 31st.
for consulting, in case if the patient and the patient's doctor know that I'll be only seeing them a short time.
All right. Thanks, Dr. Goodman. Thanks for joining us.
Thank you.